This is my second one today. I was smart enough to get a glass of water. This time, I'm a little more relaxed, but still a little nervous. I started last presentation, and I'd like to do again, just for people who are willing. I would love it if you sent a message about what you're hoping to get in a few words. If you have real questions that you're hoping to have answered. After one immerses oneself in all the literature, I'm speaking for myself anyway, it seems like what I'm presenting, everybody knows, but I think that's a bias based on just having been immersed in the literature. So maybe there are people who are actually surprised that this is a topic. And that will keep me from being too casual about the research, which suggests it is a real topic. So I'm going to look at your responses. Okay, Peter, thank you, Peter. Thank you, Lisa. As a counselor educator, I'm looking for resources to help counselors in training work through white fragility. Oh, what a great topic. Do I address that? I have been thinking a lot about that, and actually have proposed a presentation for the Black Mental Health Conference down in Atlanta in September, if it happens, on that topic. I'm going to try to remember that, Lisa. Caitlin, make sure your full name is there. I learned that I have subconscious biases. Anyone else care to join in with what they're hoping to learn? Driving questions you have. Okay. Thank you, Jennifer. Okay, I don't have a camera, but I did put a picture of myself up there on the first slide, so you could get a glimpse of me, and take a moment to see if you believe it, and if you don't believe it, why don't you believe it, or if you were alarmed or surprised or disappointed. And hopefully, I'm going to put up a real picture of me. Let's see. Could you hear me talking, Caitlin? Because I hadn't joined the meeting now that it was recorded.
Yeah, we can hear you.
Okay.
It's a little quiet, but we can hear you.
Okay. Did you say a little quiet?
Yes, it's a little quiet, but we can hear you.
Okay. Collision stigma of BPD. I should address different biases. Serve as a counselor and assist my team. Yes, the volume is low for speaker. Can I increase it, Kayla?
From your end, I'm not sure about that. Let's see here. From your end, next to your mute button, do you have an up arrow caret by any chance?
I'm going to get closer and talk louder.
Oh, okay. I'm sorry. I wish I could do something from my end.
Okay. Okay, that's a picture of me. And now, are you surprised, alarmed, disappointed, or maybe nothing? That's a picture of me. Or maybe that's a picture of me. Or none of them. Actually, none of them. I borrowed those pictures from Andrew Green. He had a PowerPoint on the web. I don't know how he used those pictures, but I'm guessing the same way, asking people just to assess their responses to these images. And he did give me permission to use them kindly. Okay, I'm gonna now put up on the screen several demographic categories, and I identify with one item in each of those, and you can just review them and see if you care one way or another, if you notice any preference. One way to understand bias, of course, is just our preferences. And I have at some point in my life displayed one of those clinical symptoms, and you might look those over and notice if you think I'm more or less trustworthy as a presenter, as a future counselor. You might do the same with my education. You might do the same with my residents, depending on which of those I would call home. So I kind of wish my earlier presentation were second after this one, because I talked in that presentation a Buddhist approach to bias, stigma, discrimination, prejudice. And it's much about paying attention internally when we're confronted with images, or in this case, ideas on a screen that would describe me or not describe me. So these are the objectives that I advertised, looking for biases at the societal level, what I'm calling comorbid biases in the healthcare system. Comorbid because they can include both mental health and physical health. Insider biases, specifically in the mental health field. And then bye-bye biases, possible correctives for what our biases and stigmas are. I'm summing those up in these three questions. Is it actually an issue in mental health counseling? Is it an issue in my own mental health counseling? And that question can be read in either of two ways: as a counselor, or maybe on the receiving end of counseling, or for instructors. Boy, there's all possibilities for bias in the classroom, even in the content that's selected, not to mention how it's delivered. And then, of course, what can be done about it. So these are examples from the broader culture. What I'm calling the ballot box. This was a study where letters were sent to representatives, and the letters were identical except for the names, and they used names that were putatively white or putatively black names, and they found that overall the putatively black names received far fewer replies from the representatives. And this was true regardless of the representative's political bias. So true for, say, Republicans and Democrats. It was not true, that is, it balanced out when the representative was themselves part of a minority group. This study looked at the impact of the composition of jurors and found it was in, they looked at felony trials in Florida between 2000 and 2010, so over a decade. And they found that when the juries were formed from an all-white base pools, they convicted Black defendants 16% more often than white defendants. But if even there was one Black juror in the jury pool, then that difference disappeared. This has to do with the academic institution. There was a study of over 6,500 professors at top US universities covering almost 90 academic disciplines and 260 different academic institutions. Professors were contacted by fictional prospective students who were asking to discuss research opportunities and to apply for a doctoral program. And they were, the names of the students were randomly assigned gender and race, white, Black, Hispanic, Indian, or Chinese, but otherwise the messages were identical. And they found that the faculty were significantly more responsive to white males than to all other categories of students. The title of this article was "What Happens Before? A Field Experiment Exploring How Pay and Representation Differentially Shape Bias on the Pathway into Organizations." So they were actually considering the prejudice and discrimination that happens at the front end and limits opportunities for, in this case, prospective students. So on the topic of automaticity of thought, which is sort of the core issue behind implicit bias. Of course, Freud put the unconscious on the map. In more recent times, I've identified a few big names in this field. People probably have heard of Daniel Kahneman. The Nobel laureate economist. I think one of his earliest articles on automaticity of thought was in 1973. The Thinking Fast, Thinking Slow book is much more recent. If people aren't familiar with that, it's the idea that we kind of operate at two levels of thought. One that happens fast and automatically without conscious awareness, and then one that's much slower and more deliberate that we are aware of. A social psychologist by the name of Barr made big this concept of priming. One of his earliest studies was in 1996. That's the idea that clues in our environment that we're unaware of can affect our behavior. For instance, they've done studies showing that a person who's holding a cold drink and meets somebody for the first time is more likely to judge that personality, that person's personality as being cold and distant. And the opposite is true if they're holding a warm drink. And of course, I would guess most people have heard of the implicit association test that Greenwald designed, and these two researchers have brought into popular culture, including in a book by Gladwell, is that his name? The book Blink. And of course, this test, I would guess most people are aware of this, but I have a resource link to it at the end of the presentation, and I can say more about it then. I do want to note that uh, when I first the proposal for this presentation, I had an idea of implicit bias in the IAT test, the implicit association test. I've since in the last few days read much more about it and have a much different idea about it. And I'm actually starting to question how much of our biases we're not aware of, or we couldn't be aware of with a little bit of effort, I guess. Maybe more effort than we're inclined to put forward sometimes. I mentioned earlier much of the work around recognizing biases and prejudices is paying attention to our attention. And that's what a lot of my earlier presentation was about on the Buddhist approach. Much of the work of the mindfulness is about training attentional skills and putting those to intelligent use. So these are my assumptions. I'm just going to make clear. I've got strong assumptions, kind of moderate assumptions, and then I've got a soft assumption. My strong assumptions, these are the ones I feel confident about. We all have many preferences. We live our life from moving from one preference to the next. Preferences influence our motivations, and our motivations shape our behavior. The more moderate assumptions, we're seldom aware of what might be motivating our preferences in any given moment, and we routinely choose behaviors based on what's more expedient, more convenient, more comfortable, more efficient, or in some other way preferential, despite, I'm suggesting, an inkling to act differently. And then my soft assumption, I'm going to posit it, but I'm not going to base my life on it. We make many substantive decisions and perform consequential acts based on unconscious motivations. I'm going to pause there and invite clarification questions, disagreements, or any other thing you want to add. Okay, nothing, so I'll move on. Caitlin?
Yes, I'm here.
Okay, good. It's sometimes you just wonder if you're still connected. Well, I wonder if I'm still connected and I don't know about it. I see a chat, so I'm gonna check.
Yep.
So is your so-so assumption that inkling is so is your so-so assumption using inkling for intuition? You know, thanks for that question, Kathy. When I used that word inkling, I thought, what an interesting word that is, because it's not that scientific. But, you know, it seems like I've been reading a fair amount of phenomenology recently. And you know, people end up, very smart people writing about very abstract things end up using kind of ordinary words because they're the best ones available. Um, and I kind of I don't claim to be in that class of people, but I would claim that I used inkling just because it's kind of, we know what it is, um, and I don't know if I can define it any better. Intuition to me, sometimes maybe, but I think it's a little actually more grounded. Intuition to me has a kind of ethereal, almost metaphysical uh, aspect. So inkling is just like, uh, it's like a second voice that you're just ignoring, I think, or maybe, yeah, you're choosing a different voice above it, but you know it's there. I hope that answers your question, and thank you. Like a hunch. Gut feeling might be good. Yeah, gut feeling might be good because the hunch thing is, um, it's more, it's, yeah, it's a good question. And I'm going to leave it to a phenomenology philosopher. But I hope that, but I really appreciate the questions, Peter and Kathy. Okay, in healthcare, biases. Schulman and 12 others in 1999 did a study. They showed doctors patient histories and asked them to make judgments about heart disease, and they were much less likely to recommend a procedure called a cardiac catheterization to Black patients, even when the medical files were statistically identical to those of the white patients. Green in 2009, that's the gentleman I borrowed the images from, 2009 or 2000, yes. 220 physicians in the Boston and Atlanta area were given a clinical case vignette. Half of the physicians were shown African-American patient. The other half were shown a picture of a white patient as they read the vignette. Except for the race, the information was identical. And they found most physicians did not explicitly name any racial biases. However, they conclude that their study represents the first evidence of unconscious race bias among physicians and its dissociation from stated or explicit bias and its predictive validity. So they had them take the IAT before or after, sometime concurrent with the recommendations, the medical recommendations, and found that their implicit race bias could predict their likelihood of bias in their medical recommendations. So they suggested physicians' unconscious bias may contribute to racial ethnic disparities in the use of a medical in medicine. Okay. Okay, a study in 2012 was on the topic of prescriptions. This was a review looking at 61 comparative analyses, 12 classes of medication for cardiovascular health, a total sample of almost 2 million people. Their conclusions: individuals with severe mental illness, including schizophrenia, appear to be prescribed significantly lower quantities of several common medications for medical disorders, largely for cardiovascular indications, although they didn't want to make any claims about what the intent. But it has been shown, I think, repeatedly that severe mental illness is much less likely to get proper medical care. And this is about professionals' attitudes towards people with drug and alcohol dependence. And they found that health professionals generally have lower regard, less motivation, and feelings of dissatisfaction when working with people with substance use disorders. These are a couple of common occurrences that seem to happen in the medical profession. People with dual diagnoses, medical and comorbidities. Um, there's this effect known as shadowing, where a physician assumes a person with some mental illness, some psychiatric condition. When they're describing symptoms, they attribute those symptoms to their mental illness, when in fact they could have a legitimate physiological need and physical ailment that needs attention. And thus, conditions are often overlooked in people with mental conditions. I see a chat. Health and gender biases or just racial, good question. Well, I think, in fact, that first one I mentioned, Shulman, I'm not sure exactly which one, but one of them definitely included women and men, white and black patients. So it does include gender regarding health. And then I'm not sure what you mean exactly, but there's substantial evidence, as I just mentioned, that for instance, regarding schizophrenia, mental health does show up in medical professionals apparently prejudiced health recommendations. I think we're probably all pretty, I'm guessing, again, familiar with what this amounts to in terms of healthcare for people with mental health conditions. Some of the barriers to the access are, of course, consumers' felt sense of prejudice, and then the quality of care, as I've suggested, has to do with the provider's prejudices and biases. Stigma, which is what this conference is all about, and I don't need to spend much time on this, but I just did want to mention, because they've been such giants in the field. Irving Goffman, his book in 1963 called Stigma, Notes on the Management of Spoiled Identity. For anyone that's read anything about stigma in the literature, most people go back to Goffman's conceptualization of it now, almost 60 years ago. And he described the mark of stigma as an attribute that is deeply discrediting and reduces a person from being whole and usual to a tainted and discounted person. More recently, Bruce Link and Joe Phelan have done huge amounts of work on stigma. And importantly, they've come up with this modified labeling theory. This gets into the question that's often debated. I had a debate with it with my own professor. Well, is it the labels that actually stigmatize people, or is it the behaviors that sort of rightfully, I'm using scare quotes, earn the diagnostic label? Link and Phelan came up with sort of the 5 steps that happen when in labeling. And importantly, I think they contributed the ideas that it amounts to a status loss for a person who has a diagnosis, is given the label of a psychiatric diagnosis, and that this whole process of labeling, it is contingent or depends on power differentials between the people receiving the diagnosis and the professional who is assigning it. Um, this is another, I think, another giant in the field, Bernice Pesco-Solido, and she wrote a review in 2015 where she sort of complicated the idea of stigma to refer to an entire complex of concerns, not just. I think the idea is that it needs to be understood as capturing a great many different items. Lincoln Fellon had pointed out earlier how ill-defined it is, or variously defined it is, which makes, of course, research difficult. And so that she complicated the notion. And in fact, this is from her review, where she defines what she means by the stigma complex, having all these different aspects, targets, characteristics, and then the theoretical concepts. From an article in 2019, these researchers observed that the stigma ends up becoming a feature of the psychiatric. That's how I read this. It ends up becoming a feature of a psychiatric disorder. It's that interwoven into the experience of somebody who's given a diagnosis. Ethical interlude. I just thought it was useful to point out what's at stake here. And this is the Code of Ethics from the ACA and the APA. The APA is a little more explicit about using these words. The ACA talks in more general terms about what our primary responsibilities are in protecting clients' welfare and avoiding harm. The American Psychological Association actually makes reference to biases and prejudices. Quick note about how stigma is measured. There's several different tools or instruments. This one identifies people's attitudes in terms of authoritarianism, and that is how much people with mental illness needs to be controlled. Their feelings of sympathy or hostility is the second one, benevolence, and then whether they should be limited in terms of their access to normal features of society, for instance, relationships, employment, housing, childbearing. The devaluation discrimination scale, I recall, is I forget how many items that is. This is a scale that was developed in 2014 specifically for mental health providers. And these researchers realized all the existing scales at that point did not measure behaviors. I mentioned the implicit association test that Greenwald and Banaji have made famous. And then, of course, appropriate for today's conversations, the social distance scale. And I think I show what that looks like, those 7 items there. You might take a moment to consider a mental illness and ask yourself those questions. The beauty of this scale is that I think it of course, we all know that social desirability is an issue when doing self ratings on stigma and bias. But this has a way, I think, of putting people in the framework of actually interacting at close proximity, and sometimes once removed, that is maybe a child care provider for your children. And so I think it probably engages people a little more viscerally and probably is a little more reliable in that sense. I'm going to check for chats. a sociological background as society. I'm starting to have an inkling as societal. I don't know if I do. Maybe. But thanks, Peter. This is a woman who was actually in the mental health field as a counselor before her life was upended by her own experience of depression. This is a kind of a summary comment from the authors of that mental health provider stigma inventory. They said provider stigma may negatively influence client outcomes and service delivery, especially if providers base their behaviors on stereotyped information about other clients sharing similar characteristics. For instance, as you might guess, diagnostic labels and chronicity of conditions. So that gets to the issue of automaticity. And we could hardly be faulted as mental health practitioners for automatically assuming somebody with a label is going to display characteristics similar to someone else we've known or witnessed or heard about in the media with that label. 2004, this study decided that psychiatrists and the general population have a tendency to want more social distance if the described situation is becoming familiar with a person with mental illness. So these studies are looking specifically at mental health providers. They found, again, that they didn't differ either negatively or positively from public attitudes. Nort et al. Summed up the general public has as many negative stereotypes about people as mental health professionals. So despite our best attitudes and intentions, implicit data that mental health providers have unconscious negativity. Some additional studies, 2013, this was a sample of over 1,400 psychiatrists at a Brazilian Congress of Psychiatry. They rated responses on 3 scales: no stigma, unobtrusive stigma, or great stigma. And the majority of psychiatrists fit into that category. 2013, Hansen, they did a cross-sectional study, 140 staff and 140 patients. And they found that, this was in Sweden, they found that negative attitudes were prevalent among the staff. And most negative attitudes concerned whether an employer would accept an application for work, willingness to date a person who had been hospitalized, and hiring a patient to take care of children. So the social distance scales. Patient attitudes were overall similar to the staff attitudes. So they found a reflection in the patients reflecting the staff attitudes. They even shared the most negative, in the same categories of most negative attitudes. This gets back into the issue of recommending treatment for severe mental illnesses. A literature review in 2010, 19 studies, 12 different countries, attitudes of mental health professionals, generally positive, but significant negative attitudes. They found these beliefs persisted in mental health professionals: dangerousness of clients with mental illnesses, skepticism about their potential for recovery, and an unwillingness to be in social close proximity socially. I'm going to check questions. Individual X rather than referring to him. Oh, great point, Kathy Driggers. And hopefully I'll get to a comment about our use of language. Wall updated his study in 2015 and found these things. This is a study in 2019 of 40, it's a review of 47 studies. At the top there, you see mental health professionals, mostly negative, four studies reviewed. Psychiatrists, mostly negative. I thought some of the best studies actually asked clients. I made some reference to, a moment ago about patient attitudes. In 2017, NAC and others made this comment. People with lived experience of mental illness commonly report feeling devalued, dismissed, and dehumanized by many mental health professionals. Wall wrote a book in 1999, Telling is Risky Business, Mental Health Consumers Confront Stigma. He quoted one person, it's anecdotal, the worst discrimination I've faced is from so-called mental health professionals. 2010, Brenner and al. Found that that research illustrates the importance of interaction between staff and clients variables in determining outcomes. And they found, what did they find? Perceptions of discrimination were a significant predictor of treatment completion amongst patients. This study found that more than 17% of patients experienced discrimination when treated for physical healthcare problems. More than 38% of participants felt disrespected by mental health staff. So this asks what might be some of the causes. The broader culture, that was mentioned, I think, early on in one of the chat comments. Goldstein pointed out in his book called Deranged Psychopath and Victims Who Go Insane that deviance and abnormality are culturally defined. Eleanor Longden, who herself has recovered from schizophrenia, mentions that in different cultures, societies, and historical areas that hearing voices has been characterized differently depending on the time and place. Knack and Patton in 2014, a report for the Canadian Mental Health Commission said, we're not a clean slate when we go into a health profession. We're not without stigma. We have influences from the broader culture. And of course, many of those are found in the media that we're exposed to, which generally have highly negative characterizations of people with mental illness. The workplace culture can contribute to biases. People's beliefs about the causes of conditions, whether they're to blame for a condition, whether it's biologically predisposed for a condition. I mentioned people's beliefs about the chances of recovery, people's dispositional traits. They've used scales of authoritarianism in a person's personality or disposition and correlated it with their attitudes toward mental illness. Um, they've also evaluated people's ideas of others getting what they deserve, what they call the meritorious view of the world. This refers to providers having preferences for this or that kind of mental health need. I think there's probably few among us who don't think of ourselves as aligned with a particular niche of client, and sometimes that's interest, just pure interest. Sometimes it's talent, and sometimes maybe it's bias. In terms of, wow, recommendations, it's important to make people aware of competencies of persons through direct contact, although that has come into some question how much contact really affects our attitudes. This study suggested that connecting people with the larger cultural climate to help them understand how their biases take hold and develop is important. This study showed that there wasn't too much effect in anti-stigma campaigns, and this one too found that contact, while maybe initially effective, tended to wear out over time. Again, emphasizing people's capacity to function. The meeting people where they're at has to do with getting a good sense of what knowledge they have, what awareness they have, and what enthusiasm they have for learning about stigma. This study suggested that it's important not to overgeneralize the success of one anti-stigma campaign or effort to another, that they need to be contextually appropriate. NAC and others recommended 6 different items, and you can see them in the middle of your screen, maximizing outcomes. The top half of that bubble are the 6 recommendations they gave, emphasizing the importance of testimony from people who have recovered from conditions, contact in multiple ways and at multiple levels, skill teaching, dispelling myths associated with mental illness, and of course, choosing somebody who's enthusiastic about delivering any sort of education or anti-stigma effort. This is a 2020 article from Pesco Solodido, and they did a longitudinal study at the University of Indiana where she is a faculty member, and they engaged the whole entire campus on an anti-stigma campaign on the campus, including the students. And they found good success, actually. And this study is important because it's recent and because they've integrated many of the things that we've learned over the years about what makes for a successful anti-stigma campaign. That it's community-oriented, so it's more localized, that it engages local members. They've taken the recommendation that's in the research about integrating a university and of course, following up over time. Many studies found that anti-stigma efforts tend to wear off if they're not giving sort of booster shots. Oops.
we got kicked out of your PowerPoint, John. Was that the last slide?
No, I'm not sure what happened. I pressed the wrong button.
That's okay. We can see it now again.
Oh, good. It's back. So what can be done based on what we've learned about fighting stigma? I'm suggesting an ethical inventory. I like the phrase from 12-step literature about ruthless, fearless and searching, or fearless and I think it's fearless and searching moral inventory. Where does and along with paying attention to attention, where does my attention go? Where does it drift off? Where does it dodge and divert? What are my preferences? How flexible are they? What are my assumptions about people and categories of mental conditions? How rigid are those? One could avail themselves of the measures, for instance, the social distance scale or the mental health stigma inventory. Paying attention to the words we use, in terms of educating oneself, reading up on stigma literature to be aware of what biases exist and thereby priming oneself to notice their own. At the interpersonal level, advocating within an agency or for instructors at a university or for students with their professors for more education, engaging other students, universities, people in the agency, requesting that things be done, and prioritizing this issue. This is a quote from a New York Times article. This is one of the researchers that I cited earlier, who was pointing out that it's important for us not to let ourselves off the hook. Okay. I see chats. I'm going to see if there are any questions. 10-minute warning. Thank you, Caitlin. I'm late.
We've got about probably about 3 minutes for questions till the next presentation.
Thank you, Andrea or Andrea. Any questions? You're welcome, Jack. Thank you. Caitlin, how are we going to are we sending PowerPoints to the school?
Yes, if I can, yes, let me send you my email.
Okay, Jack, I can send it directly to you.
And we'll also be posting the video recording of it as well.
You're welcome, Hannah. Thank you. Okay. So